Okay, today we're going to finish talking skeletal system. This is appendicular division. We talked about the axial, and the axial basically is that inline brain, skull, sternum, ribs that we talked about. So the appendicular is everything else. This is going to be the attachment of the upper extremities and the lower extremities. So pretty straightforward. The pectoral girdle, basically we're going to the shoulder girdle. This is going to be your scapula on the backside, the clavicle on the front side that attaches, and this is going to help articulate basically with the humerus bone. Now, the clavicle also articulates with the manubrium, kind of comes across up on top of the sternum area. So, that's the area we're going to concentrate first off. And basically, this is going to help with position, helping that shoulder. I'm going to show you that joint, but it's basically a free-floating joint. And this is where a lot of injuries can come from, because that's basically your shoulder joint is mostly capsule and muscular. So your rotator cuff is a big portion, so it can be a lot of injuries that we're going to deal with. So let's start off with the clavicle. Again, it's that S-shaped bone. You can see the sternal end where it articulates with the manubrium, and then it comes across on what's called the acromial end, and that's what's going to basically form one of the upper anterior aspects of your shoulder joint. And this is also where a lot of muscles are going to insert when we're dealing with your deltoid around the shoulder, especially your anterior delt. And then you're going to get some other ligaments that are going to come across there, and tendons that'll rotate through. So clavicle, again, kind of went through there, and that's going to attach on the front side. The scapula is going to be the back side. And I'm going to kind of move ahead to the picture, because I really like doing pictures. They make a lot of aspect. So when we're looking at this, this basically is going to be the picture of the scapula. And if you look, right in here is going to be where the humerus attaches, and basically it articulates with the glenoid cavity. So you've got a portion of the scapula really is formed at the joint, and the clavicle is going to come right up in here by the acromion process, and that's what's going to help feed into this area. So when we're looking at it, this is going to be the anterior side, posterior side coming across. So I'm not worried about you knowing all those specific fossas and joints and such there. Basically, the scapular spine right here is going to be the supraspinosus fossa and the supraspinatus. Again, these areas I'm not really worried about, so I'm going to kind of skip on there. But then what we do come down, and I really like pictures, so sticking with these, is going to be our humerus bone. So humerus bone is going to articulate into that joint, and it's really going to be that rotator cuff, and the capsule is going to be dealing with this area. So again, this area right here talking about is the epiphyseal area, diaphysis, and epiphysis. Proximal, distal. So basically, this is, again, another long bone. And so we've got compact bone, spongy bone, spongy bone. That's going to be the main aspect, really, that I want you to work about. I'm going to skip through a lot of these slides. There's a lot of different areas that you do not need to know. So I'm not going to go over specifically where the grooves are, all the different anatomy for this lecture. We'll talk about things on the other aspect. But basically, the humerus is going to be an area that rotates in and fits in with that normal upper joint. And then down below here is where we're going to basically be hooking up with the ulna. And the ulna is going to articulate in this area. And when I get into the area, that's where that's going to come in, with that trochlea area down below. So, moving forward, here is now our ulna and radius. So, if we look at anatomical position, the radius is going to be most lateral. Ulna is going to be inside. And this is going to be your thumb side out. So, you'd be palms down if we're looking anatomical. So the ulna is what actually really articulates with this division of the humerus, is going to rotate here. And it's more of a hinge type joint. So the olecranon process is this portion right here. And that can be broken in a lot of these injuries, because that humerus can come straight down and just crack that bone about right through here. Again, this would be in the radius. These are basically little fosses that rotate here, but pretty much free-floating type bone. And we can see a lot of fractures and injuries with there. I'm going to skip through most of this here too. You should know the positions, and anatomically I think we've already discussed in previous the different type of flexion, extension, positions, and everything from there. So I'm going to skip through a lot of this area here too. Again, with the way this rotates, if we put our hand and we do a supination or a pronation type of area of that hand rotating in, you can see how the bones actually cross over each other, and they'll actually rotate and spin around that bone, and that allows your hand to rotate and come in. So supination, just imagine a supination is your hand coming in like this. Pronation is your hand going like this. So anatomical position, if we're out, and if we pronate, it rotates in. If we supinate, basically imagine holding a cup of soup is supination. Not going to go over all the bones in the hands. The big thing I want you to know is we have the carpal bones. So imagine your hands drive the car. So those are the carpals in your hand. Your feet walk on the tar. So they're the tarsals are going to be the bones of the feet. And we'll talk about theirs. And then the phalanges. So carpals, metacarpals, phalanges. That's as detailed as you need to know there. And I'm going to skip through, again, more of these slides. And that'll basically talk about the upper portion. So now we're dealing with the pelvic girdle. So the pelvic girdle is everything that attaches to the spine. And actually, the sacrum is part of that pelvic girdle, as we can see here. So here's the sacrum and the coccyx. Even though this is part of the axial, it is also kind of helps and rotates into the pelvic girdle as well. So if we're talking axial, technically the sacrum is part of the axle. And then when we start getting to the ilium, the ischium, and the pubis bone, those are really what makes up our pelvic girdle. These three bones are then going to be fused, and this at age 25 will be fusing your iliac to your sacrum as well. So those will get eventually fused as well in here. And then this outer portion, this is basically what's called the acetabulum. You can also see it right in here. That's what's going to rotate with the head of the femur, and a capsule is going to basically attach across there, and that's what's really going to hold that neck of the femur in place. So ischium is going to be the upper body, ilium is going to be back towards the back where our buttocks is, and the pubis bone is going to be our most anterior aspect. And then there'll be an articulation, as you saw, and I'm going to move on to this slide here, where we have the pubis symphysis, and this is a cartilaginous area that holds those bones together. There is some cartilage areas that are built in these spots, especially in women, more so than men, which allows stretching and allows some opening of an area here, but they're ligaments that come into. Men actually have a more closed pelvis because we don't have to lower the earth, where females have a larger opening and a bigger angle to allow for babies to pass through the birth canal. Those are going to be the main difference. But again, ilium is going to be in this back area, top iliac crest. This is going to be that ridge you feel when you're pushing from the outside. Pubic bone, this is going to be these ridges that you're pushing down when a patient is laying supine and you're checking the pelvis. And then the ischium is going to be back and going to be the portion more towards the buttocks region in the back. Remaining portion, so we've got the femur. Femur, basically largest bone, long bone in the body. It's got the head that articulates with the acetabulum. Comes into what's called the femoral neck or surgical neck. When we talk about hip fractures later, this is the portion that's broken. So when we talk about hip fractures, it's not actually the hip that's broken, it's actually the femoral neck that needs to be replaced. The greater trochanter and the lesser trochanter, this is where the capsule is going to be attaching, and then it also will attach onto the hip in here. So this is basically capsule and muscle, which really holds this in place. So with really strong bones, that capsule will probably tear and you'll get dislocation anteriorly or posteriorly. With elderly people, the capsule is going to be strong and the bones are weaker, so more likely you'll get a fracture into this area than you will get a dislocation. Again, epiphyseal area up in here, hard compact bone goes back down to epiphyseal and spongy bone down below. And then this is what's going to articulate with the knee and with the kneecap right in here, or the patella. So again, as we're coming in here, epiphysis, diaphysis, epiphysis. And then here we have our condyles that are going to interact here with the tibia plafond, here with the patellar region. That's about all I really want you to know about the femurs as well. When we deal with the tib and fibula, the tibia and the fibula, the tibia is what rotates. This tibial plafond is this upper surface. That's what rotates with the knee, the femur at the distal shaft. And then this also rotates with the patella as well. This is your tibial tuberosity. This is that hard ridge and this long ridge or crest you're going to feel. And so if we're looking to do an IO, this is one of our landmarks we're going to be looking for. Again, epiphysis right here and above, diaphysis coming down. So usually we'll find this ridge, we'll find the knee, and 2 fingers down is going to put us in this nice flat spot right here, which has access to our spongy bone, and that's going to be our placement for an IO. Lateral aspect is the fibula. Now this is actually a free-floating bone. Again, a little articulate and facets right here and right here, and then this will make up the ankle down below. So outside, lateral fibula, inside, tibia. Medial malleolus, lateral malleolus. And this is what's going to help develop the ankle bone, and I'll talk about that. So again, down here, big things you want to know: tibial tuberosity, medial malleolus, lateral malleolus. Fibula is always lateral, tibia is medial. And those are the big aspects there that I want to deal with on this. Lots of fractures associated with these 2 bones down below. Again, these are what we call our distractor injuries. When we see this, not a lot of blood loss, a lot of pain with it, and it can be distraction with the deformity that people think that's going to be the main area where the problem is, but it's really, that's not our huge area that we'll be dealing with. A lot of ligaments around that, so I'm going to go down around the ankle first here. So here is starting to get our ankle bone. So again, we call these bones of the foot our tarsals, because again, we're walking on the tar, so that's the tarsals. Our ankle joint is going to be made up of this bone right here called the talus. This is articular cartilage right in here, and it's going to rotate and fit right in between that tibia and fibula. So this bone, this talus, is going to be right here. Medial side right here is going to be the tibia or the medial malleolus. Outside here is going to be the lateral malleolus or part of the fibula. So I'm going to go back to this picture here, and here's that talar head is going to fit right into that area, right into here, and then there's going to be capsules that's going to be surrounding that whole area and holding that joint in place. So you can imagine if you fracture this bone right here, that head could actually push that bone out because now it's not attached and your whole ankle can just move. Same as if you twist your ankle and that ankle, that bone and the talus and the foot twists inside, that head's going to push out. It pushes against this bone until it either ruptures the ligament or breaks the bone and causes that to push out. Same thing as if you collapse inside your foot, you can actually break this bone as well. Talking about IOs, again, here we're talking the epiphysis again. There is a spot also, right if you follow this medial malleolus up, right where it joins right in the spot, again, epiphysis down here, you can actually put an IO. It is one of the locations, not one in Spokane County, but it is a location you can use where you can tap right into this area also for an IO. All right, back to the foot. So we're dealing with the tarsal bones. Again, this is the calcaneus and the talus are the 2 names I do want you to really know as far as the tarsals. Calcaneus can be fractured a lot. I saw a gentleman fell 12 feet off a roof, landed on both his heels, so you can get a lot of compression fractures in areas in here. I'm not going to have you worry about the different type of fractures that can be named. And then the talus. Those are 2 bones I want you to do know. Otherwise, tarsals, metatarsals, and phalanges. So pretty similar to what we're dealing with in the hand. Again, all the names in here, I'm not going to have you guys responsible for knowing those. So that really kind of brings up the foot and organizes out the bones of the foot. Our next aspect is going to be our articulation.